Very good morning to everybody, and thank you organizers for the opportunity. Thank you, Dr. Prashant, for laying out a beautiful foundation for how the KRAS testing has to be done, and my topic has been made much simpler after that. So we have seen a lot of discussions over the KRAS in past many years. The lung treatment has changed over a lot as we see with more and more options coming in. KRAS mutation has been one of the oldest mutations, nearly 37% non-squamous carcinomas and 4% squamous carcinomas with a significant heterogeneity with specific mutations and co-mutations. And G12C is one of the most common variant that comprises 40% of the KRAS in total. And lung adenocarcinoma has been total molecular driven right now. And the more and more patients we screen out of it, the better it is. To all these mutations is the central mutations, is the KRAS pathway, which has its effect over all the other pathways as we see it, be it the PIK3C pathway, be it the MEK pathway. The KRAS is the central pathway which allosterically controls the GTP affinity and effector interactions for it. And the KRAS G12C inhibitors binds the GTP bound form of the KRAS G12C. And therefore, not all KRAS G12C models are sensitive. There is no clear-cut genomic determinant of the sensitivity or the resistance pattern as we see it. A lot is happening in the KRAS G12C inhibitors in clinical development. We have a range of clinical trials regarding the sotorasib, the adagrasib, the GDC6036, the JNJ, and the D1553 molecules, all showing a good in pipeline. And with these, we have recommended therapies also started from 2018. The sotorasib got approved in 2019. Adagrasib got approved 2020. The GDC6036 got approved. And now we have a lot of new numbers coming up in it. And not in yet, but there are a lot of in the pipeline. And how does the sotorasib and the adagrasib work? The sotorasib is a very selective and irreversible KRAS G12C inhibitor, and it covalently binds to the pocket of the switch 2 region that presents in the inactive GDP bound conformation, trapping them in the inactive state and inhibiting the KRAS signaling. So we discuss these two molecules simultaneously. The crystal was the adagrasib study, and the code break was the sotorasib study. Both unresectable metastatic situations, prior treatment with PD-L1 inhibitors or in combination in the following chemotherapies. And the primary endpoint in either of them was the overall response rates. And the secondary endpoints were the duration of response and the disease control rate and the overall survival. Adagrasib was given in 600 milligram twice daily dose, and sotorasib was given 960 milligram 4 times a dose. And you could see a steady state profile for the 24-hour pharmacokinetics for it. And that how is the deep response rate as we could see in the phase 1 and the phase 2 of the adagrasib trial, and as well as in the sotorasib trial. You could see the overall response rate in adagrasib was 45% and overall response rate was 37.1%. The disease control rate, which includes the stable disease, also was 96.1% with adagrasib. And with sotorasib, it was around 80.6%, meaning a very promising options for these. And if we look at the side effect profile of it, really manageable: nausea, diarrhea, vomiting, fatigue, transaminitis, increased creatinine levels, and QTc prolongation, with only 4.5% leading to the discontinuation of the treatment. And if you look at the duration of responses, you could see those responses lasted for a good duration, with the sotorasib data available for around nearly 11 months for them. Now, if we look at the progression-free survival, the sotorasib overall survival was 12.5 months, and the progression-free survival was 6.8 months with around 15 months of follow-up. So this translated into a phase 3 trial design as a monotherapy in second-line non-small cell lung cancer, the crystal 1-2 and the code break 200. And if all of them showing a promising outcome. So when we discuss KRAS G12C inhibitors, Why the clinical activity has not been so great? Because activity can be lower in the pre-treated patients. We had around 41% response rate with capatinib with 5.4 months PFS in second line, 68% response rate, 9.7 months PFS in the first line. And the KRAS G12C, as I discussed previously, is a more heterogeneous population and occurs more commonly in smokers. The KRAS G12C cancer also rewires very quickly in response to the G12C inhibition, and therefore the development of resistance is quite easy as compared to other form of it. The best thing with adagrasib is that it penetrates the brain and the CSF, and you could look in the tumor model of it. With relatively higher doses, you could see the mean brain concentration was much higher, and that's where it is very important. Also, these are co-mutated with the STK11 co-mutations, and as we know from the pembrolizumab data that the PD-L1 inhibitors don't work much better with the STK11 mutations, and that's why these are those who benefit in a poor prognosis subgroup with a higher overall response rates as compared to it. And the phase 1 trial was, which included all subgroups for it, and the prior PD-L1 inhibitors were allowed, and then it moved to the phase 1b expansion study and then to the phase. So we have phase 3 trials of sotorasib versus docetaxel and adagrasib versus docetaxel, which are underway. There are multiple combined trials in phase 1 and phase 2 studies. Frontline treatments as single agents in KRAS mutant LKB1 mutant cancers, it is there. And frontline studies in combination with pembrolizumab is there. If we look at the Crystal-1's CNS cohort, especially, the CNS metastasis was present in around 42% of the patients with the KRAS G12C mutated non-small cell. In adagrasib, it was which, as we saw, there was a good intracranial penetration. The response rates were around 33%, with the intracranial disease control rate around 85% of them. And if we look at the objective response rate, it is 37%, and disease control rate was 79%. So adagrasib concentration exceeded values indicated of CNS penetration and anti-tumor activity inside the brains also. And the durability and the depth of responses were nearly 9.6 months duration of response, with median PFS of 5.6 months in those with brain metastasis. And the dose which was usually given was a 600 milligram BD. And therefore, with the intracranial response rate of 32%, the duration of response not reached, it serves as a very important clinical efficacious and safe drug. And also with sotorasib, which was approved in May 2021 for the treatment of adults with KRAS G12C mutated non-small cell lung cancers who received more than one line of therapies, with a 2-year overall survival of 32.5%, median overall survival of 12.5 months, and around 1 to 3 of prior lines treatment taken, with 81% being the platinum failures. And that this is the ASCO update for it, with showing an overall response rate of nearly 43%, disease control rate of 80%. And as we see, we have a lot of secondary cis and trans mutations that develop in the tyrosine kinase pathway of it. There is also a histological change from adenocarcinoma to squamous carcinoma in the mutation pathways for it. And that's why it is very important that the responses are, these KRAS mutations are extremely difficult. Now, the presence of the co-mutations, especially the LKB and the KEAP, makes them immune resistant sort of it. And that's why the mutant KRAS is an ideal tumor antigen target. The KRAS mutations has a high clonal and driver mutations, which are central to the biology of it. And that's why a lot of adoptive tumor vaccines and T-cell therapy are going on. These are to especially the, as we say, the failure of the T-cell priming and the factors leading to the non-inflamed cold time. That's the background of it. And therefore, these three novel mRNA-based vaccines have been developed in various phases of development for in combination with the immunotherapies, be it the Nivo-EP or the Pembro, and they are showing a lot of promising results, especially with the engineered T-cell therapy, the CAR T-cell therapy, and the BiTE T-cell therapy, all coming into the adoptive T-cell pathways in these tumors. And you could look at the preclinical data for it. The mouse models shows a very promising outcomes with it. The limited TCR constructs may restrict eligible HLA types and complicate trial accrual, and HLA loss constitutes potential mechanism of resistance to them, and there's a potential for allogenic strategies. And therefore, KRAS has become a very promising target for the CAR T-cell and also the BiTE cell therapy. The intracellular nature of the KRAS makes the direct antigen binding more creative and indirect approach. The mesothelin marker in the CAR T also has a very promising opportunity to develop the adoptive cell therapy in the genomic subset of the non-small cell lung cancers. And that's why there is a unique immunological toxicities with the cytokine release syndromes and the ICANS that are associated with it. To summarize, KRAS is a variable time and a specific co-mutations, making a highly tolerogenic time. Driver mutations such as KRAS constitutes ideal targets for vaccine and adoptive cell therapies due to their clonal natures. And the recent advances in tumor vaccines has led to multiple KRAS vaccines in various phases in combinations with the PD-1 inhibitors. And these engineering T-cell receptor strategies targeting KRAS are currently being evaluated. And therefore, it promises great options. And there are a lot of emerging options with the SHF2 inhibitors, the pan-EGFR inhibitors, the PD-1 inhibitors, even the CDK4/6 inhibitors, and the FGFR inhibitors, all in this. That's the end of my talk. Would love to answer any questions. Thank you for this.